is the second speaker. Initially he had trouble getting in. I was so worried that he will not make it. Dr. Wan I Faisham, was a professor in the Department of Orthopaedics at Universiti Sains Malaysia. He specializes in musculoskeletal oncology and traumatology, and is currently in Prince Court Medical Center, Kuala Lumpur. Dr. Wan I Faisham has published over 70 research papers and 3 textbooks, and has received several awards for his contributions to musculoskeletal oncology. He'll be speaking on minimizing blood loss at surgery to improve oncological and functional outcomes in musculoskeletal tumors. Dr. Wan I Faisham.
So my talk will be minimizing blood loss at surgery to improve oncological and functional outcome in musculoskeletal tumor. I'm a tumor surgeon, mainly doing sarcoma. My main part of the topic is to minimize blood loss and to prevent transfusion in this major surgery. We are interested that the blood transfusion have generally negative impact on cancer survival, in general for the cancer survivals that established in the literature. But just to share a few literatures on sarcoma, does this blood transfusion really have a negative impact? And it has shown that in early 90s, there's quite a number of papers in 1980s to 1990s, and as well as a present paper on single center as well as a multiple center study to show that the cancer survivals have negative impact with blood transfusion, especially during surgery or post-operative, or while build up the patient for chemotherapy. Why it is important to have bloodless oncology? Bloodless means that the surgery is bloody for me. It is important that we have to minimize bloody surgery and prevent blood transfusion, because evaluation intraoperative margins as well as control of contamination is very important to prevent local recurrent that translates survival outcome of patient. So the whole entire topic, I'll talk about soft tissue sarcoma in general, as well as bone sarcoma, and we'll talk about a concept of a wide margin surgery, the compartment resection that generally will minimize the needs of a blood transfusion and avoid marginal. There will be a risk of contamination and local recurrence. That also translates bleeding intraoperatively. Of course, it is a multidisciplinary approach with hypotensive anesthesia as well as medications post-operatively, and inputs of oncologists pre-operatively in terms of controlling the growth of the tumor and to prevent the bleeding intraoperatively. Why so important about margin? Margin translate risk of local recurrence. In sarcoma, when we go very near to the margin, which is the intraoperative field will be bloody, there's needs of blood transfusion, there's more risk of local recurrence. So most of the time, we try to get a wide margin surgery with a cuff of a normal tissue to improve a local control, to achieve a wide surgery, and this will prevent local recurrence and translate the survival. Local recurrence usually carry a negative impact on final survival and systemic failure of tumor control, of malignancy control. In soft tissue sarcoma, what surgeon can do as local measures is to minimize the blood loss, discussion with anesthetics, intraoperative hypovolume with a MAP of 60, 70s. Generally, we clip all the vessels from main vessel by exploration, as well as clip the main perforator vessels to the tumor, and slow surgery to minimize the blood loss, coagulate everything. And this is very important. Plan surgery with a good MRI and minimize blood loss absolutely will control the margins of the tumor for us to achieve a wide margin. And it translates the needs of a blood transfusion because everything is well-controlled surgery. Even in a huge tumor, you can see that with a proper clipping of a perforated vessels to sarcoma, that will minimize the risk of bleeding intraoperatively, and that translate a good oncological margin. Which is compared to last time when we talk about sarcoma surgery, then most of the anesthetic will prepare 5 or 6 pints of blood. But nowadays, because of a modern technique of surgery and the need of blood transfusion become less and less, and most of the time we don't need a blood transfusion intraoperatively. This is an example of what we are doing, sarcoma surgery. Well planned with MRI, identify the major perforator vessels that we have to ligate to control before we remove the whole entire tumor. That absolutely will minimize the need of bleeding, minimize the needs of blood transfusion. That include good MRI, PET scan, assess the vascularity of the tumor, and this translate to surgery. You see, the MRI shows the very aggressive vessels very near to the tumor that can be clipped intraoperatively and prevent a major bleeding, and subsequently minimize the blood loss intraoperatively, and subsequently minimize the need of a blood transfusion or no blood transfusion. This is very important in terms of oncological clearance, or what we call to achieve a good margin, wide margin surgery to prevent local recurrence of this cancer, which is very important, that translate the systemic oncological outcome of a patient. And even in major massive surgery, retroperitoneal surgery like this, with hypotensive anesthesia, clip all the perforators to the main tumor and secure all the bleeding and mobilize the vessels away from the tumor, there's still less risk of bleeding, but the surgery a bit slow. And the most important thing is the oncological outcome. The margins of the tumor is clear, and that translates the local control as well as a final survival outcome of patient. This one, secondarily, lessen the needs of a blood transfusion even in a massive and major surgery like retroperitoneal surgery like this. Second topic is bone sarcoma. When we talk about bone sarcoma, it is very vascular tumor, and most of the time the needs of a blood transfusion. But with modern techniques of surgery using the tourniquet and control surgery, compartment resection of the tumor, and the need of a blood transfusion is minimal nowadays. Why? Because it follows the same principle. Mobilize the vessels, clip all the perforators vessel to supply the main tumor, and control the bleeding, and that will translate the good surgical field for us to control the margins of the tumor, and this translate minimize the risk of local recurrence and good outcome of the in terms of local recurrence and systemic control of the disease. How we get this is by a good preoperative chemotherapy that will shrink the tumor, will minimize the risk of vascularity, and of course, the most important thing will kill the remaining tumor. And in general, intraoperatively, it is well controlled, less vascular, and the margin can be well controlled to achieve a good oncological margin and minimize local control. And most of the time, the need of a blood transfusion is less. This is part of a resection. One of the things which is important, when we remove the tumor, we have to reconstruct back with prosthesis. And this lead to a significant bleeding. We rest for a while and allow reperfusion to the limbs and put a tourniquet again for us to prepare the bone defect with a prosthesis. And it is important to do this procedure less bloody. Why? Because cementation is very important in a dry environment. Once we cement the whole entire thing and minimize the risk of acute bleeding, and then we can release tourniquet, at the same time achieve a good stabilization of a prosthesis and good dry environment for prosthesis junction. That also will improve the survival of a prosthesis for early loosening. So this is the whole entire idea of why we need to have a clean, bloodless field and very nice, which is very important in terms of local control of the disease, as well as a long-term survival of a prosthesis. And post-operatively, there's still a chance of bleeding. In our practice nowadays, on top of tranexamic acid, especially intraoperatively, post-operatively, we use a tranexamic that significantly reduce post-operative drain, blood loss post-operatively. And of course, it's established in the literature that it reduces the need of a blood transfusion almost half, 40%. And this is, from my practice, is very good to prevent the need of blood loss as well as blood transfusion post-operatively. This is my regime: 1 gram post-op, as well as local injection. Significantly, the needs of a blood transfusion following a drainage is less with a tranexamic acid. A bit on, and this is an example of one of my patient. Good chemotherapy, compartment surgery, minimize the risk of bleeding, and of course, no blood transfusion, even in a massive surgery like this. Then of course, with a good chemotherapy, systemic control, then you can achieve a good oncological outcome and systemic control even in a very aggressive and malignant tumor like this. So a bit advancement. So we use for the past 10 years argon diatomy, especially to do intraoperative and control bleeding in aggressive bone tumor, which particularly we want to salvage the joint in giant cell tumor, but this is a vascular tumor. How we minimize intraoperatively rebleed is to use argon diatomy. This improve in terms of killing remaining disease in the surgical bed, at the same time minimize risk of acute blood loss following acute release of tourniquet while preparations the bed for control of the disease. Another thing that which is very interesting, past few years that we are using ultrasonic scalpel to do an osteotomy. It's combination of heat and cutting procedure that significantly really minimize the acute bleeding following bone osteotomy, which is compared to ordinary traditional method of osteotomy, because it combined the cutting together with a heat that generally coagulate the needs of bleeding from the bone. And nowadays, small surgery and planned surgery, especially avoiding a major vessels, major neurovascular structure, can be done with computer guided. This will minimize error for good local control of a tumor resection. At the same time, because of guided surgery, will avoid sudden injury to the vessels as well as the nerve, and significantly reduce the size of the wound, and it translates the need of blood loss, the need of blood transfusion because of blood loss intraoperatively. And absolutely, with a minimal surgery, there'll be a reasonable good outcome. This is an example on how we try avoid a major axillary artery by using navigation that to prevent a risk of perforators to the vessels and minimize the bleeding intraoperatively and the need of blood transfusion. And of course, minimize surgery, and you can have a reasonable outcome. All right. Okay. In conclusion, is there any improvement in terms of a sarcoma surgery for the past few years? The need of a blood transfusion even in a vascular sarcoma surgery become less or less because of a new concept or same concept of a wide margin surgery, compartment resection that significantly translate the bloodless surgical field and bleeding intraoperatively. And absolutely, it avoid a blood transfusion even in a massive surgery like a sarcoma surgery. Thank you very much.